Dr. Stuart Finder, Director of the Center for Healthcare Ethics at Cedars-Sinai Hospital in LA. How are you holding up over there?
Doing pretty well. Things are actually looking pretty good here. So we're settled into being at home, and skies are bluer than they've been in years. So it's good.
I've understood, if I read correctly, that the Earth has been shaking less just with the reduction in traffic, and we can read that on seismographs.
Yeah, that's what they're saying. I mean, in LA, it's pretty amazing because literally, I wasn't joking, the sky here is bluer than it's been in years because there's so much less driving, less pollution. Right. It's beautiful.
It's incredible. So would you share with us a little bit more about your work in quote unquote normal times, if there is such a thing, prior to COVID-19? What keeps you busy?
So I'm the director, as you said, of the Center for Healthcare Ethics at Cedars-Sinai. And our center, the core work that we do is clinical ethics consultation, which means that we work with patients and families and physicians and nurses, social workers, chaplains, anybody who's directly involved in patient care whenever they're facing challenging decisions. So there's myself, and then I have two younger colleagues that are full-time, and then one very part-time other colleague. And we do close to 300 consults a year. So we're really involved doing that kind of clinical work. In addition to that, because Cedars-Sinai is an educational academic medical center, we do a lot of teaching with medical trainees, residents and fellows, nurses. So we have a lot of different educational activities that we are responsible for. And then as the director of the center, I also am involved in a lot of more higher level conversations with administrators, the board of directors and all that about challenging ethical issues for the medical center. So that's sort of the day-to-day, that's what we do.
So could you give us an example of what one of those thornier issues you might be called in to consult on?
Yeah, so there's all different kinds. So one kind is when we have patients that are coming from often SNFs, skilled nursing facilities, or they may be coming from the streets. They're homeless, but what they share in common is that these are people that don't have anyone to speak on their behalf. So it's surprising that we have people, again, homeless people, you might think, oh, we understand that, but we have people who are in their 80s or 90s and their family has all died or moved away, and they no longer have capacity, so they can't speak for themselves. And so when they're faced with really challenging medical options, one of the things we have is a whole process to be able to make sure that we can represent them and do what's best for them. So we get a lot of those kind. A lot of people don't realize, because Allegheny County is one of those counties in the country that has a lot of old people. At Cedars-Sinai, because of where we're located, when you look at the Medicare or Medicare population over the age of 85, so these are the people that are considered the extreme elderly, no offense, mom and dad, we actually have the highest number in the entire nation of the over 85-year-olds in terms of our patient population. So we have a lot of these kinds of patients. So that's one big chunk. We also deal with a lot of situations where patients and families are really struggling with trying to figure out what's the right thing to do. They're facing two sets of options, neither of which is good, and you're trying to figure out which is in some sense the least worse. And just to be able to work through the values that prompt people to say this is better considering versus that. So we do that. Because we are a Jewish hospital, we also deal with a lot of issues having to do with halakha. We have a very large chaplaincy program. We have within that program 2 rabbis, but 4 Jewish chaplains, plus 2 full-time priests that are actually permanently on loan from the diocese, and then 7 or 8 non-Catholic Christian chaplains, plus an interfaith chaplain. So there's a lot of those where religious issues, medical issues, personal values all intersect. And so again, we help facilitate those conversations.
Sure, and you're stepping into rooms and situations in the most difficult of times imaginable, right? You don't have the luxury of time and getting to sit back and study for a while, but are making very practical rulings in real time.
That's correct. However, one of the things that I think is really important to note is, and I don't, this could be seen by some people as offensive, and I don't mean it as offensive. In our ordinary everyday life, a lot of us wear masks, all sorts of masks. We hide behind roles, we hide behind appearances, um, things that don't actually allow ourselves to really be who we are. In the kind of situations that I and my colleagues find ourselves in these clinical contexts, even though it is really intense, it is also where people are most authentic. And you really are dealing not with the masks, they're gone. You're dealing with the purity of human being. And that's actually very enlivening and very positive.
So speaking of masks, if you will forgive the poor taste of that segue, I imagine there have been a number of challenging issues, hopefully theoretical, that have sprung up or arisen due to COVID-19. I understand that you were leading the team to write some hospital policies as you looked at the potential for a shortage of equipment to help those who are most vulnerable. Can you say a little bit about some of those nightmare scenarios and how the discussion or decision-making processes went?
Yeah, so as you correctly noted, we have to be prepared for the worst case scenario. And LA was relatively early in having people stay at home and canceling all large meetings. I actually was just thinking about this as I was organizing myself for the day, that it's been, I think, 5 or 6, I think it's 6 weeks now since at Cedars-Sinai we canceled all meetings. Um, so that we were really trying to enforce the distancing, the physical distancing that is essential to prevent any kind of spread. In the midst of that, we started very early on trying to think about what would happen if we actually see the surge that at that time was happening in Milan. It wasn't happening yet in New York City, but there were the burblings of it beginning. And so we had to think about what would we do if our usual 108 ICU beds filled up. First, the question was, could we expand? And in fact, at this point, should it turn into some second or third wave where we actually do have that kind of surge, we are now prepared to have 340 ICU beds. So we have tripled our capacity in preparation. But even so, that would not be enough if, again, the same thing that happened in parts of New York City or Milan, Tehran, Madrid, there's places all around the world where the medical system was completely overwhelmed. And that's the kind of then policy work that I have been leading the effort to develop, in which we want to have a rational way of making sure that we can try to save the most lives with the least amount of resource use so that we can continue to save the most lives. And so it has to be not just for a short period of time, but a long period of time. And so there have actually been a number of plans that have been developed around the country. And what I and my colleagues did is we reached out initially just around LA and then actually across the entire country to ethics colleagues and medical colleagues who were working on these plans, and tried to take the bits and pieces that made the most sense. And many people may now know that there is a general framework that has been pretty well accepted across the country that uses a combination of different kinds of medical data to then prioritize people as lowest priority to highest priority for receiving ICU care. And the goal, again, is to take people that you know as best as one can know these things, that you can get them through the ICU, get them through hospitalization, and end up with someone who will continue to have a healthy, long life. So it doesn't make determinations of whatever your baseline was in terms of if you had a disability or not, just plain old your age or not. It's really going to look at Do you have any kind of end-stage organ failure that would make it very unlikely for you to survive in the ICU? And then do you have underlying medical issues that would already foreshorten your life, such that if you have this new thing on top of it, the chances of you surviving may be okay, but you won't live more than a year. And so if we could save people that will live 5, 10, 15 years, and this is all based on medical criteria, because one of the things that's really important is that we don't smuggle in any kind of personal biases or evaluations of people's quality of life or self-worth. We don't want to do that.
Imagine that, I don't even know how to frame this, that you're dealing with such thorny issues at a time of deepening public distrust of professionals or the medical community. Who is involved in that? How are you hypothetically, God, thank God, how would you document this? Who is involved in that decision-making process? What is the process of community outreach, or how much do you share in advance versus as it happens?
Yeah, no, this is actually a key question, and one of the ethical pillars, for lack of a better word, that we are committed to is the idea of transparency. And so as we've been doing this, we've involved community members who were part of our bioethics committee as reviewing this and giving input. And one of the next steps, and because things have settled down, it's actually now we have more time, and that's really good, is to develop how we will share this with the broader community, because it's not something that you wait until somebody is in the hospital critically ill before you let them know. It has to be upfront. So that's key. In terms of the decision-making part of this, we actually have worked out a process where we have small triage teams that will be responsible for this, that are different than the people who are on the front lines taking care of the patient. Because if you're the physician or nurse who's actually taking care of a patient, you shouldn't have the burden of having to make the decisions about whether they qualify or not to move forward. So it has to be at a step removed. But you have that step removed, just like the normal clinical work I do, we have to interdigitate with the frontline providers. So letting everyone know, not just out in the community, but even within the hospital, this is a big issue, because Cedars-Sinai, unlike, let's say, whatever now is the main hospital at UPMC, since there's so many different hospitals, where it's a fully academic hospital where everybody is a professor of medicine or professor of surgery, this and that. Cedars-Sinai is still a community hospital. So of our 2,400 or so medical staff members, only about 400 are on faculty. So 2,000 of them they're just out there practicing physicians. So it's also even helping our own community know, let alone our patient community. And it's actually a really challenging issue. And we haven't done that yet. We're still working on trying to figure out how to do that. And we're grateful that right now our numbers have actually decreased over the last 2 weeks. They're steady. We probably have at least a sixth of our hospital is COVID-related patients. And that's going to stay for months. But we're nowhere near that disaster that we were fearing.
So many follow-up questions. Let me jump around in our script a little bit, and then before I go off the rails yet again, you said about a sixth of the hospital is treating those who are wrestling with COVID-19. How are your employees situated for equipment? Is the hospital in a good place at this moment to be taking care of that many people?
Yeah, our administration is actually pretty amazing. Part of it is because we're such a large and prestigious institution, we have a lot of connections, and we've certainly taken advantage of that. We also, even though we are a community hospital, we are a large academic institution. So as a non-university based academic institution, in terms of NIH funding, I think we're like number 10 in the nation. So we have a very robust research community. So we have turned actually to our researchers who have come up with incredible ways to create some of the supplies we need. Since, as everyone knows, the personal protective equipment, PPE, is in huge shortage everywhere. But that's not it. I don't know if anybody saw the other day when President Trump was holding up one of the swabs, then he pulled out a Q-tip. It was a kind of weird sort of thing that he did. But the swabs are also in short supply. So we actually have people who are using 3D printing to create the sticks, and then we're using other research supplies, so our research community, to create our own swabs. We have people using 3D printing to create our own face shields. A lot of people here in LA have been making surgical grade masks and gowns. So we're tapped into all of that. So we're actually doing pretty well. As for the staff holding up, again, our staff has been really pretty amazing because we have such a well-organized system. We've been able to keep all of our staff employed, even though we dropped our census by, we were, if we went back 2.5 months ago, our daily census was close to 900 patients. And up until the beginning of this week, we were down to about 520. And that was because we made space for in case we got all these patients. That's a lot of staff then that suddenly were not working. We did not lay anybody off. What we've been doing is keeping everyone fully paid, and people were rotating through so that people could continue to work. So not everybody was just, the ones who worked and everyone else was off. It's that it was rotating through. So that gave a lot of relief to the stress. And we have about 14,000 employees total. And we have a very low number of patients who have, or staff who have actually tested positive. I believe that it's 5. So incredibly low. And they're probably, it's not related to being at the hospital, it's that they live in LA.
Or it's incredible, and it speaks to how well-resourced and creative your community is to make that happen. I commend you for it.
So one of the challenges, just because you said a key word there, which is we're really well-resourced. I think another thing that we've been doing is trying to help some of the other hospitals in the area, because LA is a big place and not everybody is as fortunate as we are. And this goes into part of the commitment as a historic Jewish hospital, that we have always tried to, not in any way above board to seek publicity, but below board to reach out to those who are in need and provide what we can to help them, since we have the resources. And once we see that we don't need them, we try to help others.
A quick clarification question from one of
Sure.
our viewers: 5 employees or 5% of the hospital's employees?
No, literally 5 employees.
5 individuals.
Just 5 individuals. So it's hardly anything. So so it turns out that we are the West Coast Ebola institution, i.e. when Ebola was very big, what was that now, 3 years ago, 4 years ago, and there were patients who were mostly Americans who were working in charity in Africa who were exposed to Ebola. And if people remember, they came back. There was a place that they went to up in the Midwest, and I believe it was in Nebraska. There's also an Ebola center there's one in Atlanta where the CDC is. I think there's one in DC, one in Boston. Anyways, there was not anything on the West Coast. And so we actually were awarded the contract. And so we have a biocontainment unit. And so we've been practicing and drilling just as part of the routine for now several years in case something happens. So as a result, when this happened, in terms of people learning how to don and doff, put on and take off all of that protective equipment, we have hundreds of nurses and hundreds of physicians who practice this all the time. So I think that's really helped because we have an experience in how to do that. Because it turns out that within the healthcare world, the largest source of infection is self-infection. people were taking off their masks, they get stuff on their hands and they touch their face, they're exposed. They're taking off their gown, they get it on their hands, they touch themselves. It turns out it's a lot harder than you think to be able to take this stuff off when it's contaminated and not contaminate yourself. So we've been practicing that long before this. I think that's what's really helped.
Wow, it's incredible. You mentioned other hospitals, and I want to ask a question about involving other hospitals in ethics. So as I look at the ethics around autonomous or self-driving cars, there's consideration of national standards, right? So if each car company did its own, I, as the consumer, would make a choice which one fits my values and only drive that car that will make X choice in Y situation to protect Z individuals. I could imagine the same would be true in healthcare. If Cedars-Sinai was making one series of decisions that you were transparent about, and the hospital down the road was going a different way, that might set up some tension. How broadly are these issues shared among your colleagues?
That's a great question. And as I mentioned earlier, one of the first things that I did is I actually reached out to colleagues at UCLA, which is about 5 miles from us, so still on the west side of Los Angeles. There are several Kaiser Permanente facilities within our area. One of my best friend is somebody who leads the ethics program at the largest of the Kaiser facilities here in LA. So I reached out to him. I reached out to one of his colleagues at the Kaiser West LA. So that's about 3 miles from Cedars-Sinai. Reached out to people at some of the Catholic hospitals, the Providence system, some other community hospitals down in Torrance, Huntington Memorial. So really, that was one of the first things I did for the reasons that you just said, which was we actually have to do this as a community. And I think that that's actually one of the things that, independent of the particulars we're talking about now, this idea of community and recognizing how most of our life always already is within community structures. That's actually what it means to be human. And so instead of somehow running away from that, this is the time to be more fully cognizant of that and embrace that. So just as you said, we needed to create community standards. And it turns out that everybody is now agreed on the approach of how we would do any kind of rationing or any kind of prioritization of, who does what and when. Across LA, actually across California, across the nation. That people at the University of Pittsburgh were actually one of the first to put out the particular structure for this. Doug White, who is a physician at UPMC, who also does ethics, promoted this. And it's been picked up really across the entire nation.
Wow. You mentioned that Cedars-Sinai is a Jewish hospital. Indeed, I have a number of classmates from rabbinical school who have spent time in the chaplaincy program that you mentioned. I'm curious how Jewish values play into this conversation, whether COVID-19 or just all of the issues you're dealing with.
So yes and no and yes. I want to do the yes, no, and then yes. So we are a historically Jewish hospital who still maintains its deep ties to the Jewish community. So there's a lot of hospitals around, Montefiore in Pittsburgh at one time was a Jewish hospital, then it got sold. It kept its name. I assume it still kind of has the name, but it's not a Jewish hospital. It's just, it has the name. There are hospitals all around the country that were historically Jewish. They sold out to bigger organizations, and some of them nominally have some sort of Jewishness in them. We are still deeply a Jewish hospital. And so the yes part is that at the foundation, the key pieces of our hospital in terms of commitment is very much rooted in our Jewish history and Jewish values. The no part is that it actually is consistent with the Jewish hospitals and the Jewish hospital experience in the United States. is that you take care of everyone in need. So Jewish hospital, unlike the Catholic hospitals, which were set up really for Catholics, by Catholics, the Jewish hospital has always been for the entire community. It also is for Jews. It's where Jews could work, it's where Jews could get care. But if non-Jews lived in the area, non-Jews were always welcomed and always have been welcomed. Non-Jewish physicians, nurses always have been on staff. So in that sense, part of the commitment of the Jewish hospital has always been to be more ecumenical, to take care of everybody. So as I said, our chaplaincy staff is very large. Our director of spiritual care services is a rabbi. He's modern Orthodox. His name is Jason Weiner. And he's very involved in all of the work that has any kind of implication for Jewish values. So he's part of my bioethics committee. He's part of when those unrepresented patients that I talked about, the people who don't have anyone to speak for themselves. I use Jason all the time in the small groups to help with the decision making. So in that sense, we go from the commitment, yes, the no, as in it's not that we are enforcing a traditional halachic view, back to the yes, where we try to take into account the variety of all religious commitments, but the undergirded set of commitments are the values of Judaism in terms of the importance of life, the importance of charity, of being a light unto the nations, of making sure that we're not just doing good for ourselves, but we're actually reaching out to others.
And on the subject of religion, my particular training leaves me better suited to be teaching a Torah study class than to be subjecting others to interviews. What else should I be asking you? What else would you like people to know who are listening to us?
Well, I want to go back to something that I just said about community. I've actually gotten a couple of interviews recently from some newspapers and media people about this issue of what do you do when you see someone who's not wearing a mask, right? In California, we actually are now required to wear masks if we go into any kind of business, if you're in any sort of communal setting. What about if no one's wearing a mask? Or you're at the grocery store and on the floor in the grocery store, there's lines every 6 feet. And so if you are in line, you're supposed to stay 6 feet, and people don't do that. What are you supposed to do? And a lot of people are responding to the someone not wearing a mask or not standing in line at the right way with a sense of, you're supposed to do this, with that sort of authoritarian, I know, and you are wrong. And so media have been reaching out saying, is that the right way? Is that the best way? And I've been trying to remind people that, remember, why do you drive on the right side of the road here in the United States as opposed to wherever you want? Okay, you do it in part to protect yourself, but you do it mostly to protect others. Because if you think about it, all of those traffic rules are designed so that we don't harm others. Why do we wear a mask when we're out in public with COVID-19 being as widespread as it is? Not to protect ourselves. This is actually all to protect others, which means we're tapping into something that is at the really basic level of what it means to be human, which is we live in communities and we are community oriented. Our lives, in ways that we don't even think about it, we just take it for granted, or we just do it by habit, is oriented to take care of others. And I think that this is what we need to start thinking about in terms of how to respond to what's going on with COVID-19, whether it is when should we start opening businesses again, or how do we support our local businesses during times like this when they're closed. There's so many issues that we have to be much more now conscious about that normally we would not be, about what it means to live in community, and then do those sorts of things. From the little things, like when you walk by and you see somebody, say hello. Because it was actually the rabbi from Tree of Life who I learned this from. when people started using the term social distancing, he spoke up and said, no, 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 no. It's physical distancing, not social distancing. In fact, because we are maintaining physical distance, we have to recognize that that is for the sake of social cohesion. So it's not a social distance at all. It's a social coming together. The physical distance reemphasizes the coming together. So we should be doing those things that bring us together, saying hello to strangers. If you see someone who isn't wearing a mask, ask them. I was actually in an office yesterday and I did not have gloves on. I had a mask on, but no gloves. And a woman who was wearing gloves said, well, I see you're not wearing gloves. Why not? Now, she didn't say it as, why aren't you wearing gloves? She actually asked a genuine question, and it was a good question, and I was prepared to answer. I have gloves in my pocket if I need to put on a pair of gloves, but I don't just walk around with gloves on. I think that there's the opportunity for us to really be more open and engaged with our community, our neighbors, our friends, our families. This is an opportunity to remind us of the importance of that, as opposed to seeing it as you're wrong, I'm right.
Dr. Stuart Finder, Director for the Center of Healthcare Ethics at Cedars-Sinai Hospital, I am so grateful for your time this morning. Thank you.
Thank you. Hope it's been helpful.